Today we're going to cover chapter 23, which will talk about the treatment of cardiac arrhythmias. An arrhythmia can be defined as any significant deviation from a normal cardiac rhythm. And if arrhythmias are left untreated, disturbances in normal cardiac rhythm can occur. And this could result in impaired cardiac pumping ability, and certain arrhythmias are even associated with cerebral vascular accidents, cardiac failure, or other sequelae that can result in fatality. The overall usage of the antiarrhythmic drugs has declined recently because of the development of non-pharmacological interventions. And these particular interventions include implantable defibrillator devices and specific surgical interventions that offer a more permanent solution to rhythm disturbances than just long-term pharmacological management. Many of the drugs which we're going to talk about that are actually used to treat arrhythmias actually have a pro-arrhythmic effect. That means they actually have the chance of inducing a arrhythmia as a side effect. So even though they're intended to treat arrhythmias, they may actually cause an arrhythmia that was never there before, or actually exacerbate the patient's current condition, the patient's current arrhythmic condition. Patients may be on these drugs for particular musculoskeletal disorders, and the way this class of drugs actually works is they have a positive effect on when the patient is undergoing physical rehabilitation, because these drugs essentially stabilize the heart rate and allow the patient to engage in more strenuous exercise and functional activities. So it's really important for you all as physical therapists to understand how these drugs work, understand the side effects of these drugs, be able to recognize when the patient is suffering from these side effects, and know how these drugs are used so that you can maximize your treatment regimen with your patient. Now we're going to talk about the action potential that occurs in the cardiac cells. So for the most part, this is very similar to the action potential that occurs in neurons, but it is a little different because there is more of a role of calcium during the plateau phase, which we'll talk about when we get there. So the cardiac action potential has these particular features about it that can distinguish it from the action potentials in the nerves and the muscles. So let's start with phase 0. And as you may imagine, phase 0 is the phase where rapid depolarization occurs. And this occurs very similar to how it occurs in the nerve and muscle cells. What's happening is there's a sudden influx of sodium ions into the cell. At some threshold level, the cell membrane suddenly becomes permeable to sodium ions because of the opening of the sodium channels or the sodium gates. And again, it's similar to you get this spike, which is similar to what you see in the skeletal muscle depolarization. So at phase 1, this is actually an early brief period of repolarization. And this occurs because there's specific potassium channels in the cell membranes that open up and they allow for potassium to leave the cell. Phase 2 occurs after the action potential undergoes its plateau phase, primarily because the calcium channels open and there is a slow, prolonged influx of calcium ions into the cell. Because the efflux of positively charged potassium ions that occurred in phase 1 is balanced by the influx of the positively charged calcium ions, the cell's potential remains relatively constant for a brief period. So you can see here, we don't immediately start to go to repolarization. There's somewhat of a level graph, a level line at phase 2. So this calcium flux and this potassium flux is essentially stabilizing and causing this distinctive plateau feature that can be seen in the figure on the right-hand side. The plateau phase is really important in cardiac cells because it prolongs the cell's effective refractory period. And as you can recall from cardiopulmonary or from the action potential talks that we did in pharmacology, the refractory period is the time interval between the successive firing of action potentials. And this plateau phase is really important because it basically enables the heart to enter a period of rest. And this period of rest is also termed, as you all know, diastole. So during this phase, the cardiac chambers can fill with blood before the next contraction occurs, which again is cardiac systole. And then we get phase 3. So at the end of the plateau, repolarization is essentially complete. And this is primarily because of the closing or the inactivation of the calcium channels. And this inactivation terminates the entry of calcium into the cell. And then the repolarization phase is completed by the unopposed exit of the potassium ions. And then we get this strange phase 4. And phase 4 consists of a slow, spontaneous depolarization in certain cardiac pacemaker cells. Don't worry about the particular cells, but there are certain cells that this depolarization occurs and we get this spontaneous rise again. And basically the reason this occurs is because the membrane ion channels allow for the continuous leak of sodium ions into the cell, along with a gradual decrease in potassium exit from the cell. Also, the intracellular release of calcium from the myocardial sarcoplasmic reticulum helps to regulate the automatic depolarization that initiates each heartbeat. So the coordinated action of the membrane ion movements and the intracellular calcium release causes this progressive accumulation of positive charge within the cell. So again, this is going to cause the cell to become more and more positive until it reaches a threshold, and then phase 0 can be initiated again. So please review this slide. This slide is very important. I want you to understand what is influxing, what is effluxing. Take really detailed notes on everything I just said. So again, this action potential is the action potential that's recorded from a Purkinje cell, which is one of the cells that helps the ventricles contract. Remember, we have the cardiac pacemaker cells in the SA node, then the signal goes to the AV node, travels down the interventricular bundle of His, and then eventually goes to the Purkinje fibers, which will allow for ventricular contraction. So again, please go over this slide until you've mastered it, you're able to explain it, you're able to draw it. You will see questions from this slide, I guarantee it. As I mentioned before, in both pharmacology and cardiopulm, we have pacemaker cells in all aspects of the heart, but the pacemaker cells kind of conglomerate in the SA node, and those are the pacemaker cells that are responsible for the sinus rhythm or the generation of the sinus rhythm. And even in the absence of any type of neural or hormonal input, these cells will automatically generate an action potential. So this is one of the contributing factors to when you actually take the heart out of the body, the heart will continue to beat because it's still having some type of electrical conduction that is happening. So these particular pacemaker cells that are found in the heart have the ability to depolarize spontaneously because of a rising phase 4 in the cardiac action potential. The cardiac action potential is normally conducted throughout the heart in a coordinated and very predictable pattern. And this pattern is drawn for you in the figure on the right side of the screen. And again, I covered this on the previous slide, but I'm going to say it again because it's really important. The way the electrical signal is conducted. So the action potential, again, is going to originate in the sinoatrial node or the SA node. And it's going to be conducted throughout both atria via the atrial muscle cells. And then while it's spreading through the atria, the action potential will then reach the AV node or the atrioventricular node. From the AV node, the action potential is going to be passed on to the ventricles through the bundle of His. The bundle of His is again composed of these specializing conducting cells known as Purkinje fibers. And as the bundle leaves the AV node, it's going to divide into both left and right branches. And these left and right branches are what is going to supply the respective ventricles. So the action potential is actually distributed to all parts of the ventricles through the bundle branches and the Purkinje fibers. And then the Purkinje fibers are going to aid in ventricular contraction. There are many different causes of cardiac arrhythmias. Some include metabolic and electrolyte imbalances, if we have any type of abnormal autonomic influence on the heart, if we're taking any drug that could induce arrhythmias, even if we're taking the antiarrhythmic drugs. Toxicity to these particular drugs can result in unwanted arrhythmias. Psychological distress is also shown to induce arrhythmias, so stay stress-free as much as possible, practice breathing, practice meditation, practice being mindful, and keep your stress levels as low as you possibly can. And other cardiac diseases, including myocardial infarction, ischemia, heart failure, hypertension. These are other types of diseases. This isn't an all-inclusive list, but these are some diseases that can result in cardiac arrhythmia formation as well. And there's a plethora of both genetic and epigenetic factors that contribute to the development of cardiac arrhythmias as well. So this slide should look very familiar to you all as well. The types of arrhythmias are going to be defined by their particular characteristic heart rate that they induce. So you should all know the differences between bradycardia versus tachycardia at this point. Tachycardia is indicated by a heart rate of more than 100 beats per minute, and the sinus bradycardia is indicated by less than 60 beats per minute. Don't worry too much about memorizing the particular arrhythmias and the beats per minute. I would never test on numbers. This slide is more for your general awareness to understand and get familiar with the different type of arrhythmias that can occur. But again, I'm not going to test on particular arrhythmias and what drugs are used for particular arrhythmias. I want you to know general drug classes for this, and I'm going to reiterate these concepts on the upcoming slides. I do want you to know the general classifications of the antiarrhythmic drugs. I do want you to know how the different classes affect the action potential. So in general, with the antiarrhythmic drugs, by normalizing the rate of sodium entry, the sodium channel blockers, these are the class 1 drugs, these are the ones that are going to be able to help control cardiac excitation and conduction. So there's subclasses of the class 1 drugs. I do want you to know how the subclasses work. So class 1, these are sodium channel blockers. Again, they're going to help stabilize the cardiac cell membrane and normalize the rate of cardiac cell firing. So the class 1A drugs, they moderate the slowing of the action potential and prolong the repolarization phase. So they're a little bit, the way they actually work, by lengthening the interval before the second action potential can occur, this allows for less stress to be put on the heart. So the heart's not firing as fast and arrhythmic. So that's the whole goal behind the class 1A drugs. The class 1B drugs, they shorten cardiac repolarization, and therefore they effectively decrease the effective refractory period. And then the class 1C drugs decrease the rate of the phase 1 depolarization and slow cardiac conduction. So I do want you to know what differentiates class 1A from B and C, and definitely know for class A, I definitely want you to know disopyramide, procainamide, and quinidine. So I want you to know all the drugs that are listed there. Class B, just worry about lidocaine and tokenide. Class C, which one do I want you to know? Propafenone, also known as Arrhythmol, because this is very commonly seen. So again, class A, I want you to know all of them. Class B, lidocaine and tokenide, and then class C, propafenone. The beta blockers we're going to talk about extensively on the next lecture. The class 3 and class 4 drugs we'll talk about in the upcoming slides as well. So the class 2 drugs are considered to be the beta blockers, and they're the main treatment for cardiac arrhythmias. So as we continue to cover all this cardiac pathology, I do want you to be aware of the diverse use of the beta blockers. So I would start to generate a list of all the different conditions beta blockers are used for, because this is an extremely high yield concept for the boards. Beta blockers are very useful in treating atrial tachycardias, such as atrial fibrillation. You're going to hear atrial fibrillation called AFib a lot in the clinic. So they're very useful in treating that. They can also be used to treat ventricular arrhythmias, and they also have the potential to reduce mortality in serious rhythm disturbances, such as ventricular tachycardia. So the way they work, they're antagonizing the beta-1 receptors on the myocardium of the heart, and this is leading to a decrease in the excitatory effects that the sympathetic nervous system is eliciting and the elevating effects that the catecholamines, epinephrine, and norepinephrine elicit. So again, the beta blockers are going to preferentially, most of them that are causing the decrease in heart rate, they're going to bind to the beta-1 receptors and block the receptors. They are beta antagonists. So the mechanism of action, they're going to prolong the effective refractory period. So if we're prolonging this effective refractory period, there's no way for another action potential to fire until we reach a resting membrane potential again, and we actually hit that threshold that is induced by the sodium influx into the cell. So the beta blockers are very useful in controlling the function of the atrioventricular node, and many of the patients will get a generalized sedation or sedative effect from taking beta blockers. So if your patient is too sedated when he or she comes to physical therapy, this is something you may want to discuss with the MD. So the class 3 drugs are the ones that are going to prolong the repolarization. And these include amiodarone, dofetilide, dronedarone, and ibutilide. Actually, amiodarone is the most important one because this is the most widely used antiarrhythmic drug. I promise you will see amiodarone on the upcoming exam. So this prolonged repolarization, this delay actually lengthens, again, the time interval between a subsequent action potential that can be initiated. Therefore, it slows and stabilizes the heart rate. And the class 3 drugs actually limit the ability of potassium to leave the cell during phases 2 and 3 of the action potential, which leads to the prolonging of the repolarization phase and prevents the cell from firing another action potential too rapidly. So the ventricular arrhythmias such as VTAC, VFib, and the supraventricular arrhythmias such as postoperative AFib are going to be the primary indications for using the class 3 drugs. The class 4 calcium channel blockers I want you to know are Verapamil and diltiazem. Both of these inhibit the calcium influx into myocardial cells, and they also have the capability to alter the excitability and conduction of cardiac tissue in general. Both of these drugs are very successful in treating arrhythmias caused by atrial dysfunction, such as the supraventricular tachycardia that we see and AFib. So they inhibit the calcium influx by binding to specific channels in the cell membrane. They lead to the decreased rate of discharge through the SA node. By limiting the discharge to the SA node, everything downstream is going to be affected. So as you can imagine, the decreased rate of discharge of the SA node is going to inhibit the conduction velocity through the AV node. It's going to inhibit the conduction velocity through the bundle of His and to the Purkinje fibers. And all of that inhibition is going to slow heart rate. This is a very important slide to read through. I'm not going to sit here and read this for you, but I do want you to read through this and take notes on this slide. So go through this case study, answer these 2 questions. This is not going to be assigned as an assignment or anything like that, but you may see something on the upcoming exam coming from this case study. So I highly recommend going through this and answering the 2 questions at the end.